Hi, everyone. Thank you for joining us for our weekly briefing on preventing and managing COVID-19 in the workplace. This is Karen O'Hara. I'm the Director of Marketing and Communications at WorkCare and your moderator for today's session. Most of you who've joined us these past months know that this is our 52nd consecutive webinar, and this has been our goal to do a whole year of presentations. And if you've been with us since the beginning, we sure appreciate your participation. If you're just joining us for the first time, I'm glad you found us and we welcome you. Just wanted to let you know, moving forward from here, we're going to continue to offer the webinar, but we're going to go on a monthly schedule, doing the webinar on the first Wednesday of the month. So the next one will be on April 7th. And we'll probably extend the time. Normally, we just convene for about 40 minutes because everyone is always so busy, and we try to make it as succinct as possible. Today, in honor of our annual goal, we're going to go for 60 minutes maximum so we can take as many questions as we possibly can, and since you won't be seeing us every week. In the interim, if you have questions for Dr. Harris, our presenter, you can send them to me at info@workcare.com, and I'll manage the questions and answers when we have a lapse between sessions. As you know, when you join us every week, we do publish answers to all questions that are asked and post them on our website on the COVID-19 page. And we post the recording of every session on our YouTube channel. And during the session, those links will be posted for you in the chat. Today, if you could please post your questions using the Q&A function in Zoom, I'd really appreciate it. That way I can keep close track of them. And we'll just take as many as we possibly can. Now I'd like to introduce our presenter who's been with us from the beginning, and it's just been a great resource for all of us. We're so appreciative. It's Anthony Harris, MD, MBA, MPH. Dr. Harris is board certified in occupational medicine. He's WorkCare's Chief Innovation Officer and Associate Medical Director. He's also acted as the lead clinician for our COVID-19 response. Well, I'll turn it over to him. Thanks for joining us.
Hi, everyone. This is Dr. Harris. I'm not sure if you can hear me or not. If you can, Alexis, can you hear me? Okay, I hear everybody. I can hear you. For whatever reason, Karen is not audible here. So we normally have a beautiful introduction. I'm sure she had something whipped up to introduce this 52nd consecutive in a row here webinar. But somebody said they heard Karen's intro. Okay, good, awesome. So if you all heard Karen just fine, I could not hear Karen, and I let them know that. So we're going to jump into it because I'm sure she's done the wonderful intro here, and we'll jump into our presentation for today. We got a fun one for you today, and we're going to talk about on this 52nd week here some trends that we're seeing, and really focus in on what can we expect for the rest of 2021, and sprinkle in some pearls here of what you should be doing with your workforce to keep them safe. And we're going to keep it real. So it might sound like we're prognosticating a doomsday, but don't get alarmed. We're not. We're just trying to give you a realistic perspective of how things may play out here in the US as a result of what we're seeing trends internally as well as macroscopically abroad. So without further ado, we'll jump into our presentation for today. We're gonna, like I said, we're gonna have some fun here with number 52 in a row. It's been a fun year in regards to being able to help out in as many workforce experts as we can. And we're going to continue to have, and I use the word fun, obviously, with a deep sense of sobriety, if you would. We know that there's been a tough year, tough 52 weeks for everyone. But we're going to do our best to continue to provide up-to-date, accurate information and give insight as to trends as they play out throughout this year and as long as we're dealing with COVID-19. So with that being said, today we're going to mix it up a little bit. We're going to sprinkle in the pearls here into the clinical update, the micro, the epi, and the prevention, okay? So we're not going to save it all to the end today. We're going to just hop in, talk about trends in each of these arenas, and then, like I said, really hit what we should be focusing in on as a result of what we've seen over the last 52 weeks and what we've seen recently. So we will discuss these lessons throughout. And the first one we want to come to is really bookended by this quote here: "No problem of human destiny is beyond human beings." And President John F. Kennedy said this, right? And we certainly know that the prospect of COVID is going to be here for some time. And we want to look at these trends as we talk about the clinical encounter that we will have with our workforce on a day-to-day basis throughout this 2021 year. We know that the workforce is changing. 60% of the corporate real estate professionals surveyed recently, or back in May here, said that remote work will continue to be a trend after the pandemic is concluded. We talked about last week, I believe it was, data from Stanford pointing towards the workforce going from a kind of 5% to 20% rate of staying and remaining at home. So again, going from maybe 1 day a week of working remotely to 3 days a week working remotely. Back in 2020, we also saw that 25,000 stores potentially closing permanently and shifting the workforce away from retail. We know that if we look at how infrastructure of the US is changing as a result of the pandemic, cities are changing, right? The epicenter of many of the people who live on the planet has been shifting towards cities. And the pandemic has shifted us away from cities. And we've seen now people looking at living in the periphery, right? Living in areas where it's not as densely populated, so that the potential for spread of pandemics in the future may be less than what we've seen now, right? And so as these trends continue with regard to clinical presentation, what are we looking for, right? We're looking for a long-term game plan to differentiate individuals who present with a cold or flu from individuals who present with pandemic-like symptoms, in this case, obviously SARS-CoV-2 coronavirus. And it's something that, again, will need to be a part of your armamentarium for the remainder of this year and probably well into 2022. And we'll undergird this with information and data around vaccinations and when we anticipate herd immunity, if ever. And I know I say that again very soberly, but that might be the picture that plays out. And if we look at then potential future reports here, and we highlight a couple, this being publication in JAMA in March, just March 3rd of this year is when this was presented here and published. We look at the percentages of people surveyed that would actually receive the vaccine when it's available for their demographic. this data coming from an effort from Facebook, actually, to provide insights to the individual populations that would take the vaccine. And what we see is that 71 to 72% of responses were positive that they would take the vaccine when available. Now, if we look at then the realization that the vaccine for children is not currently available, and children obviously making up almost a third of the population in the US, 25% to a third, we know that they will still be vulnerable to COVID-19, and reaching herd immunity with that demographic vulnerability in children would be difficult, right? But let's assume that we have children vaccinated, right? Even with that assumption of children vaccinated, and we have these variants such as B135.1, right, the UK variant, we can expect a vaccination immunologic resistance, if you would, or taking people out of the realm of susceptibility to only reach 37.5%. Okay. And that estimate, right, is a very low number, right, for vaccinations. And this is in conjunction with, the particular vaccine that we have been promulgated, we're looking at a low rate of resistance, right? And so we know for herd immunity's sake that 80% of the population, if we're listening to Tony Fauci or any of the estimates that are out there based upon the reproductive rate of the virus as it stands today, 80% of the people will need to have resistance to COVID-19 to reach herd immunity. And so with these low numbers, we know that we'll be dealing with COVID-19 for some time to come, even in the face of vaccinations. If we look at another report, this coming out of the Lancet in February of this year, one extreme that's optimistically extreme, right? If we look at new generations of vaccines against SARS-CoV-2 and assume, right, that everyone in the US is coordinated, now we're talking a global resistance to COVID-19 being necessary in order to get us to a point in which we have herd immunity even in the US, right? So what do I mean by this? I mean that even if we do a great job here in the US to provide vaccines to as many people as we can, enough that we reach herd immunity, as we experience globally continued mutations to the virus in areas in which the vaccination effort is not as robust, perhaps, as the US, we may then import cases that become more resistant to vaccinations. And we will have now new susceptibilities in the US, causing us to lose effectively our herd immunity if we had it prior to the mutations that present in country, right? So again, it's a very pragmatic look at what we're dealing with pandemic-wise, not just here in the US, but abroad. And from WHO to other organizations, it's going to take a global effort to reach herd immunity globally to protect any one given country, lest we shut down, right, our borders. And we know the economic perils of shutting down borders in terms of trade and e-commerce. So we're going to be talking now about how do we put this together, Dr. Harris? Like, okay, we're going to be dealing with the workforce being susceptible potentially to COVID-19 for some time to come. What do we do, right? How do we be practical and pragmatic about, from a clinical standpoint, keeping the workforce safe, right? And risk stratification for clinical presentation is going to be key, all right? So having something in place that's obviously sustainable long-term for your workforce, such that you're able to articulate those individuals who identify and risk stratify those individuals who may be presenting with a transmittable illness like COVID-19, right, and or variant from the common cold or the flu. Obviously, you want to keep people home safely if they have a cold or the flu, but again, stratifying the risk and then appropriately getting people back to work is what's going to reduce absenteeism to the extent where you can have your workforce protected and productive safely, right? So thanks to, in this case, a artistic rendition of how you perform these type of stratification and identification of individuals, we can see an approach that, in this case, this comes from Alabama, University of Alabama, but we can see how it can be practical, how it will be necessary, and how we may identify in conjunction with your healthcare providers strategies for long-term plays to keep the workforce safe, right? So this is something that's here to stay, ain't going anywhere, right? We know that it's been a chore to try to do this internally. If you're still trying to do this internally for all of 2021, we urge you to look for partnerships. It doesn't have to be work care. We want it to be work care, but even if it's not, identifying a partner that's going to take the burden off your HR business partners, that's going to allow you to bend the cost curve and make it efficient enough through scale, economies of scale, to do this throughout the year, to do it possibly into 2022 and perhaps longer, is something that is a reality, right? So clinically differentiating symptoms into risk, that's what's necessary. That's what we're going to be stuck with for some time. If we're jumping next to look at what's happening over in the UK, over in South Africa with the variants, and looking at the vaccine efficacy, we know that the vaccine can protect against these variants, but to a lesser degree. We want to reiterate this. We've talked about it before, right? But it's another sign that not just the efficaciousness is affected, but again, long-term, we're going to see more transmissions as a result of the lower efficaciousness of these vaccines against these variants. Pfizer right now is looking at something called a third booster, right? Another shot after the first initial 2 shots that their phase 1 clinical trial participants underwent over almost a year ago. So they've kicked this off already, and they're going to continue to look at, is this something that's tolerable from a safety standpoint over the next coming weeks? And so we also know they're looking at and have looked at the efficaciousness against the variant, UK variant, the Brazilian variant, as well as the South African variant. But it is important to point out that this may be a strategy that we'll have to roll out if we're looking to getting across this pandemic in the US before the end of the year. All right. And so we'll continue to watch this trend, watch this study play out from the phase 1 piece of this study into a larger number. This phase 1 only encompasses around 150 participants. But if it goes well and the efficacy, the safety's there from an immunogenicity standpoint, then this will follow on to a larger study looking at a third shot. And if it's necessary, again, we'll see this play out in the US as a strategy to help protect from these variants as we move forward. So what's the nugget from this? In terms of the protectiveness of the vaccines against variants, against the current cases that we're seeing here in the US, what do you do about it as a organization? And this may be a little controversial, what I'm about to say. I recognize that, but it's okay, because I think it's a play that we'll see more and more of, which is from a workforce strategy, mandate the vaccine. Right. And so if we're talking mandate for the vaccine, we're talking something that is not too uncommon and popularly both in the US and abroad, right? If I'm going to go travel abroad, depending on where I'm traveling, I'm going to have to get several vaccines, whether that's yellow fever, whether that's a typhoid shot, so there are mandates for travel for vaccines that we're all used to. So the notion that we mandate the vaccine in order to get us closer to a herd immunity number here in the US, so that globally we're all better off as well, is something that I think organizations overwhelmingly so should be considering. And if your organization has not had this discussion, I think you should bring it up as the EHS professional, right? If you have an opportunity to get to the C-suite and have this discussion, it should be something that we spend more time on because we will not have a safe workforce, right? If we don't have the acquired immunity, and we'll talk about this more, the acquired immunity from vaccinations here in the US. And as we look at trends in the epidemiology of things, as we're doing right now, we're going to speak to why we're seeing these downward trends over the last couple of weeks and what to glean from it in terms of how do we double down on our strategy or how do we ease up on our strategies in the workforce as a result of these decreasing, these seemingly good trends, right, and decreasing numbers. 19.3 out of 100,000 cases is what we saw 2 weeks ago. It went to 19.9 last week. And look at this, folks. This is the first time we've seen an aberration in data. We went from 19.9 up to 143.8. Now, this is CDC data as of today, right? So lest we believe that something has gone horribly wrong in regards to the rate of cases over a 7-day rolling average nationwide, we know that there's something going on with these numbers, right? And so we'll talk about this number in particular and try to clarify what the heck happened and why CDC is reporting such a dramatic increase per 100,000 cases as of today. If we look at deaths, we saw 0.6 2 weeks ago, 0.6 last week, and 3.5 this week. Okay, so we know something's afoot, and we'll try to clarify. And this is why, if we talk about these presentations we do week to week, I know some folk have probably said in their minds, Harris, why do you represent or represent the data from multiple sources? We go over it from the CDC and then you present it in a different format such as this. I think it's important, and this is why, right? CDC reports that we've had this huge increase in number of cases. However, if we look at data from Hopkins and the data that we presented, we don't see this jump in the 7-day rolling average over the same time period. That was 2 weeks ago. This was last week, and this is today. So we see a continued downward trend in this data, reassuring kind of a deep sigh of relief if we're talking the experience here in the US of cases on the last 7 days on an average. If we look at per capita, we see 2 weeks ago where we were, last week where we stood, and this week, thankfully, again, we don't see an increase as reported by CDC. If we look at deaths, again, CDC reported an increase there 2 weeks ago where we stood based upon this data set from Hopkins, where we were last week, and a downward trend as of today in terms of number of deaths. So again, importance, we're epidemiologists, right? We have a public health duty to report good numbers. And so multiple sources of data allows us to try to understand when we see an aberration in one data set, is it accurate or is it an aberration indeed, right? So we, in this case, are agreeing with the notion that CDC is reporting numbers that ain't accurate, right? And we'll dig into that a little bit more in the second here. As we continue through our epidemiology, looking at deaths per capita, we see downward trend 2 weeks ago, last week, globally amongst nations. And this week, we see a little bump Italy is having in terms of deaths per capita. So we'll watch that to see what may be going on in Italy and are they potentially exposed to a new variant that's causing increased rates of deaths in that nation. US is continuing to see downward trend there. In terms of testing, 2 weeks ago, downward trend, last week, downward trend here in the US, and downward trend again here for the most part in the US for the number of tests done and performed. We see UK was still rising in terms of number of tests, and we'll try to opine in future talks about why we're seeing the difference between nations in regards to number of tests conducted. I have my opinions and we'll share those. So you have to tune in next week as we talk about that trend and what that may mean. We look at per 1,000 individuals, we see the downward trend continue here. In the majority of nations, we see UK, though, again, test-wise going up. Israel having a small bump there. United States still trending down for the most part as of today per capita. Positivity rate, downward trend is what we want to see in this metric and what we have seen in this metric over the last several weeks consistently. And we see that downward trend for the most part continue here up until today. And we'll continue to watch this indeed as we move forward. From an administration of vaccines, we know we are leading the way from a total number of vaccinations provided. If we see the trend continue upward, we are well over 2 million at this point in terms of daily vaccination doses administered. Israel is still number one. It has been for several weeks, from 2 weeks ago to last week to this week. We're in the number 2 spot here in terms of per 100 individuals and the vaccines administered. If we now look at specific numbers for vaccinations in the US, 2 weeks ago, we were at 82 million delivered, 65 million administered with Pfizer and Moderna, 102 versus 78 million delivered versus administered. And today, over 127 million now with 95 million administered. And we can see now Johnson & Johnson entering the marketplace in terms of distributed doses and administered doses. Again, pointing towards the data here with reports from CDC, one would anticipate with the single dose Johnson & Johnson vaccination that the number of individuals who have received and been administered the Johnson & Johnson vaccine would match those individuals who were listed as fully vaccinated. But these numbers aren't matching. So it's curious to see and understand why at this point. I don't have a good answer for you, but perhaps there is some aberration in terms of the number of vaccines distributed and administered and reported fully vaccinated individuals, particularly for the J&J. So let's look at the specifics now on the 7-day rolling average data report that we saw from CDC and try to understand and distill why we may be seeing this 143.8 per 100,000 jump from 19, right? If we distill down a layer into specific states that have reported and what's documented with CDC, we can quickly see that Missouri is throwing the average off here. This is a number of days since the 0.01 daily cases, right, per 100,000 first recorded. And we can see here over the last 7 days, rolling average, just pulling an excerpt of several states, we can see where Missouri is. And easily the average is being skewed higher, possibly by this data set. So again, reassuring that things are, the wheels haven't come off the wagon in regards to the number of cases in the US per CDC data, and we are still seeing a decline. Now, with that being said, is the decline that we're seeing a result of, likely a result of our efforts from a vaccination standpoint? Or is it a result of those individuals who have developed immunity because they have been exposed and recovered from COVID-19, right? And we'll talk about the differentiation there and the impacts potentially from a trend standpoint and some of the potential harms that we may have as a result of state trends that we're seeing from a protectionism regard. Looking at the variants and how they continue to play out in regards to population and occurrence of cases here in the U.S. 2 weeks ago, we noticed where the states that did not report any variants last week did, right? And we saw several states that were reporting variants, namely Texas, Florida, California, Michigan, right, reported more cases. And then this week, most states now, right, reporting cases. There are 3 states that have not reported any variants. But we clearly see these variants now in most of the states, and we see the numbers increase in the states that have been reporting these particular variants. And that's important, right? Because it's not until we have enough people vaccinated, right, not recovered from COVID, that we're going to start to see herd immunity and start to really get back to normal on the other side of things, right? I leave you, I want to share another quote here. The welfare of each of us is dependent fundamentally on upon the welfare of all of us, right? And this is certainly a mindset we hopefully have and carry with us in the EHS profession. However, this was, by the way, President Theodore Roosevelt. And if you haven't recognized where these quotes are coming from, these are actually the quotes that encircle the Oval Office, right? And we want to hold that in our minds in terms of our holistic approach here in the U.S. to protect every level of socioeconomic citizen here, right? Because it is going to be essential to do so well in order to get to the other side of this pandemic, and then to look globally, right? As we talk about the global effort, we want to talk about the International Science Council. This is a council that's been convened and is looking specifically at recommendations globally of how we get to the other side of this pandemic. And we want to highlight some pearls from this body that will be reporting to WHO in the next several weeks, recommendations of how to continue to deal with both short-term, midterm, and long-term the pandemic. So again, not being a doomsdayer, but just trying to be sober about our pragmatic approach to COVID-19. The pandemic recovery, we're a long ways from it, right? We have good science about the spread of the variants, and we know that how governments respond as a result will shape our encounters both domestically as well as abroad in importation of disease, and will impact our herd immunity both domestically and globally. And so this body, again, is tasked with coming up with that full picture of how do we get to the other side and back to normal. But part of that reality check is that the virus is here and here probably forever. They opine that because the presence of the virus, as we talked about before, does exist in cats and dogs, we probably will never have eradication of this virus, right? Unless we start vaccinating pets, which is not likely to happen, right? And then if we look to the future of vaccinations, we don't yet know whether revaccination will be required. That's why we just finished talking about what Pfizer is doing for a third shot after you've been fully vaccinated as a potential, because it is probably going to be a pragmatic approach as we see the emergence of new variants. We still know that it is incumbent upon decisions made by governments and how quickly we respond to the pandemic to anticipate when we're going to be on the other side of this. Obviously, we know it's not going to be 2021. We know that it probably won't be 2022. And perhaps 5 years from now, we may be talking about things getting back to normal. And these uncertainties, we know, continue to play out from a diagnostic standpoint, the vaccination standpoint. And when we can declare that we won, who knows, right? And so we'll continue to play a role here at Work Here in the future here moving forward to bring you the trends and bring you the best practices that's going to continue to keep your workforce safe from, again, a very pragmatic approach, so that it's something that is not overtaxing and overburdening your health and safety professionals, HR professionals, etc. So if we talk about the likely future and the opinions that are out there, right? That, more than polio, less than the flu, one opinion a data set points towards. We know that there are dissenting opinions out there, right? We talked about the governor in Texas opening up back to 100% capacity and lifting the mask mandate as well. And how that will play out in the state is something that we want to dig into right now, right? So if we look at what has happened abroad and try to glean insight from a potential of reopening too soon in our current environment, it likely may play out like this. This is data from Brazil. We all know that Brazil is dealing with increasing deaths as well as hospitalizations at this point in time. So let's look at what happened in Brazil first experienced last year in the summer and the fall exceptionally low cases of COVID-19, right? And they experienced this also with their R naught, their reproductive number, right? And so perhaps fittingly, they sought to reopen, and that was in November of last year, but then quickly shut things down, the lockdown, in December, right before January. And now they're experiencing, again, increases in both hospitalization and deaths. So we can learn from this, right? Because if we we know, one, there was no vaccine during this time period of low reproductive number as well as low cases in Brazil, right? And so their low cases were not attributed to vaccination efforts. Likewise, should we suggest that our low numbers and rates that we see here in the US are attributed to our vaccination effort? And the answer to that lies in the data, right? We only have a small delegation of individuals that have been fully vaccinated here in the US, nowhere near the 80% we need for herd immunity. Therefore, we can postulate that our decreasing numbers are likely from natural immunity, meaning that individuals have contracted and recovered from COVID-19 in the US. So does that make sense? Perhaps, right? If we look at, in particular here in Brazil, a case of one city in particular that experienced up to estimated 76% of individuals having contracted and recovered from COVID-19 based upon seropositivity rates being over 50%. Then we know that in that city, and this is where this data comes from, has experienced the natural immunity to keep their numbers low. But when they encountered the variant, the Brazilian variant, right, they then experienced these increasing numbers of cases as well as hospitalizations and deaths. And so when we talk about how this may play out for us in Texas and Mississippi and other states that have reopened and lifted the mask mandate, and they're back at 100% capacity, we know that in these states where the variant is an increasing force, that we may see increases dramatically so in cases as a result of these variants. And so we need to glean from that some type of strategy that's going to protect our workforce if it plays out this way, right? And so what does that nugget look like? And you probably guessed it, it's a recommendation to not deviate from best practice as it stands. So even if you're in a state where there is no mask mandate the mask in the workplace. Keep the hand hygiene there. Keep social distancing in place, because we're not through with this. We're not on the other side of COVID, and we're likely only experiencing a temporary level of success because of the broadness of infection and recovery and natural immunity, which we know does not protect from these variants to the level that it does from the wild type COVID-19 virus. And again, so if we're not learning from, we study other countries in this endeavor, in these reports, purposefully to glean insight. And I'm telling you this insight here in terms of how it may play out for us and why we need to keep these measures in place, regardless of the political winds, regardless of the recommendations, because our job is to protect the workforce, right? So figure out your level of conservatism in these states, even if you're, at a moderate level of conservatism, that's going to be better than peeling back or repealing these efforts in the workplace. Obviously, there will be a cause for having a more conservative approach if the pandemic plays out in your state with a prevalence of a variant that causes more transmissions, and that makes sense, right? But we have to dial it in appropriately for the anticipated cases that we're going to see after spring break, likely, right? We know that we're going to see people flocking to Florida, young folk flocking to Texas, where the mask mandate is not in place. And we might likely see variant numbers escalate, as well as asymptomatic transmissions that will affect many people. And hopefully we don't see that play out, but it is likely because we know that transportation or actual mobility, increased mobility, leads to increased transmissions, right? And so what does the future look like for the workplace? What do we have to keep in mind in addition to these measures that need to stay in place for now? Is looking towards kind of the long play, what we need to be prepared for with regard to workplace hygiene, right? And if we look at across the to the east and what's playing out there, they even have indoor outdoor monitors for air quality, right? And whether or not masks are required or not. And we may end up getting to that point here in the US in terms of having the level of a building's air turnover be a part of what is communicated to the workforce as well as to the general public, right? Because we know we'll be dealing with these type of situations, scenarios of transmission rate, transmission risk for years to come. So I say on this 52nd week of doing this with you all, we have to think outside the box in terms of how to protect our workforce and think contrary to what the political winds may bring, because we know because we can learn epidemiologically from what's occurring outside the U.S., and that will inform us of how to protect the workers here in the U.S. and abroad. So I'll stop there. We'll open it up to questions. And I want to thank you again for celebrating and sticking with us for 52 weeks. It's been a journey. I know it's not been fun, actually, because of the level of overutilization and reliance on the EHS, but hang in there. We're going to stick with you, and we'll continue this for perhaps another 52 to come. So thank you so much.
Okay, Dr. Harris, can you hear me?
I can hear you. Awesome.
Oh, yay. I re-logged back on. I apologize to those of you who couldn't hear my intro, which was full of enthusiasm for reaching our year goal. And just a reminder that we're going to go to a monthly sequence. So we won't be doing 52, but we'll be filling in between times with other mediums. We're working on developing a podcast series, which we'll be sharing with you when we're ready to launch that. And as always, you can use this as a resource at any time and send your questions to info@workcare.com or directly to me at karen.o'hara@workcare.com. And I'll make sure that Dr. Harris and our other subject matter experts address those questions for you. So I'm going to start out as moderator privilege today and ask the first question. Dr. Harris, in the past year that you've been presenting the webinar, we started out with, what is this coronavirus? Learning about its origins, et cetera. And now we're at this point where, we're starting to distribute vaccine. As a clinician, what is your overall impression of the experience, and what have you gleaned from it in terms of the way you practice occupational medicine?
Excellent. So what I've learned is that we really do have to have a more broad perspective of understanding trends abroad. Right? Had we paid attention to what was occurring abroad early in this pandemic and took it more seriously, perhaps, in regards to potential harm and impact to us domestically, we may have made some different decisions, not just at the political leadership level, but even at a workplace level. And for me, as a clinician, sounding the alarm perhaps sooner of a potential pandemic coming. So this journey has definitely broadened my perspective and deepened my resolve to look for macro trends from a health and wellness, from an epidemiology standpoint, and let that inform me about how we practice here domestically and how we advise those who may be at risk abroad.
That's really interesting because I had the same kind of experience. I'm a non-clinician, I'm a journalist by training, but when I first started writing about COVID back in January, and when it first was reported in China, I thought, oh, this sounds kind of serious, it's like an epidemic. And then it just blew up in such a short amount of time. I'd never experienced anything like that in my career in occupational health, and I've been in the field since 1990. And I do think a lot about pandemic planning and general disease management, prevention strategies, and the need to really, for disaster preparedness and all that kind of thinking, needing to place an even bigger emphasis on it. People being people, it's hard for them to perceive, these major events and really be prepared. So we appreciate those insights, Dr. Harris. Thank you. Now we'll jump into the participant questions. What are your thoughts on the recent CDC guidance for fully vaccinated people to meet with others indoors? Is it prudent?
I think it is. If we talk about absolute risk or relative risk, even once you've been fully vaccinated, it is low in regards to a risk of transmission in that setting in the household, right? And certainly that is what Tony Fauci was speaking to in regards to being able to enjoy in the household, meeting up with friends and family that have been vaccinated. And I think that's prudent at this point in time. Now, as we see increasing numbers of variants in various states, that recommendation would likely change, right? But at this point in time, with the vaccine being efficacious against the variants to the extent that it is, right? We're seeing effectiveness up to 80-85%. If we're talking Moderna and Pfizer, and the majority of the variants we're seeing, it's still prudent at this point, and I would definitely attend if invited, being fully vaccinated myself, a gathering of such.
Okay, good advice. Thank you. I think we've had this question before, but it bears repeating. Assume you're fully vaccinated, then you get symptoms, then you get tested for those symptoms. Even if you don't have COVID, would you automatically test positive because you've been vaccinated?
And the answer to that is no, that the test for COVID, meaning looking for genetic material of the virus, would be negative if you do not have COVID and only have been vaccinated from COVID. Because you're not replicating viral particles, only your system is primed to recognize viral particles when they're presented from a potential immune challenge. So in that scenario, you should test negative unless, for whatever reason, you have contracted COVID, and that reason likely being if you are fully vaccinated, you fall into that demographic that did not seroconvert and actually acquire the immunity to SARS-CoV-2.
Okay. If you've had a previous adverse reaction from a vaccination, and then you're advised against vaccination, but your employer mandates it, how will this be handled? If
sure, that would be
mandate there's a little bit more, sorry. If the employer's mandate an employee has adverse reaction, our company is going to be held legally liable.
Sure. So in regards to that mandate and those who have medical exceptions to vaccinations, we deal with that currently in the workforce, in situations, perhaps very much so in healthcare, where it is mandated. If you're going to walk into this hospital as an employee, you have to have a set of vaccines and a titer for some of them to prove that you've been vaccinated. And those who cannot be vaccinated have a reasonable accommodation that falls under ADA, that allows a clinician to review and document, as we do on a regular basis at work care, and then allow that individual to be gainfully employed under those reasonable accommodations with that employer.
Okay. This next question, the person's trying to understand how the same immune system that is supposed to provide immunity after vaccination somehow does not provide immunity after illness. T memory cells provide long-term immunity. What scientific studies do we have that supports this?
Sure. So it's all about the level of, well, not all about, but one of the contributing factors we understand today is that a individual who recovers from an infection of COVID-19 is imparted likely with a level of immunity against the wild type, the wild type form of the virus, right? They don't gain immunity to the same level against variants, all variants across the board. And that's now the variants you're seeing in the media are specific variants that have enough mutations to key components, i.e. the receptor binding site of the S protein, spike protein, to minimize the effectiveness of natural immunity, right? And so we're not talking about all the variants that occur through genetic drift. There's a lot of them likely, right, as a common cold. And so the immune system is recognizing and protecting us from these type of variants. Is the exceptions are these variants that have become more prominent. Now, with that being said, too, we also know there is a quantity factor to immunity, meaning that the acquired immunity from a vaccine, and studies have undergirded this, can produce up to 40 times the number of 40 times the immune response to the natural immunity pathway. And so these factors do play out in natural immunity not being as effective for these variants as opposed to acquired immunity through the vaccination.
Okay, interesting. Next question is about travel. Can you comment on states revising travel bans, for example, testing and isolation, from mandatory to recommended? What should companies do?
So likewise, when we talk about recommended versus required, it is something that, again, if you can require it, you do have a legal stance to do so, right? That at this point is no longer a question, but it is going to be, is there enough risk to support it? Right. And certainly in those scenarios in which you have high risk of transmission, as we still do today for much of the country, right, we're at levels that were alarming early on in the pandemic. We're lower than where we were, but these levels last year were alarming. There's still support of mandating these precautions for travel, which certainly we would recommend. If you can, you have the leadership support to do so, it would be prudent until we get again to the point at which we have enough folk in the US vaccinated to approach that herd immunity. That is conservative in regards to protecting the workforce, but again, we think very practical and very prudent regarding travel.
Hey, as you know, we're going for the hour, so we had just a couple more questions before we wrap up. You mentioned the downward trend in testing in the US, and we've gone over that the last few weeks. What's your opinion about why we're seeing this trend? And since we're not going to be meeting weekly now, what do you anticipate we may see when we reconvene on the 7th of April?
Sure. So when we talk about the downward trend of testing, it's likely a result not of tests not being available or access to testing, but rather individuals not participating in testing to the extent that they used to previously. And that's a result of, again, the exposure, the transmission, and the recovery from COVID-19. And again, if we look at seropositivity here in the US, in some states, high as 22%, of the populace, right? Those individuals aren't showing up to be tested because they're not, one, not symptomatic, and two, have recovered. So we see this play out not just here in the US with decreasing testing adjacent to decreasing cases, but we see it play out in other nations as well. And that is likely the genesis of the decreased testing. Now in the UK, we see more surveillance testing perhaps being conducted, which is why we're seeing their testing going up versus here in the US, where surveillance testing has not been relied upon substantially. And I think that may be to our peril when we talk about, as the second part of the question, when we reconvene here, to our peril if we continue to see upward trends of the variants play out, in which we still have susceptible populations because they've only enjoyed a natural immunity to this point versus acquired immunity through vaccination.
Okay, two more questions. If people are vaccinated and we're approaching herd immunity, what factor does the mutation or variants play in when we reach that point? Will they have an influence on herd immunity or not?
Absolutely. And if we look at perhaps the most dramatic impact, it undergirds the notion that we have to have a global concerted effort at combating SARS-CoV-2. And I'll explain that through this illustration. If we achieve herd immunity here in the US, we have 80% of the population vaccinated and now not susceptible likely to the virus, both wild type and variants. And we contrast that with nations, and particularly the socioeconomically challenged nations, the poorer nations that don't have access to vaccinations, and we see that in the data. They will still continue to have higher levels of infection and thus higher levels of mutations that would potentially be imported to the US and escape the acquired immunity even, right, from vaccinations. So that would have a dramatic impact on herd immunity globally, and obviously then at that point affect nations that have international travel, which could see the importation of vaccine-resistant, quote unquote, viruses.
Okay, it's interesting. I just heard a report from a public health official in an African nation speculating that one reason their case rates haven't been as high as they expected is because the average age was 20. So they have such a young population. So that might be something we could talk about in a future webinar too, like age demographics and their influence, in addition to diversity of populations and underserved populations.
Sure.
Thought that was interesting, being in the older categories. So we have the last question for this week. Can you address loss of taste and smell as a distinguishing symptom in COVID versus the flu versus allergies, and how they would be applied in workplace screening?
Sure. We've incorporated loss of sense of taste and smell as one of the symptomatic metrics to put you in a high-risk category for COVID-19. In fact, effectively, it's pathognomonic for COVID if you're presenting with even that by itself in this current pandemic. So it definitely is something that, and we won't go into the pathology of it in terms of why you develop it. We covered that in the previous talk, but certainly moving forward, it will likely continue to be a pathognomonic trigger for a required isolation at that point if individuals present with loss of sense of taste and smell.
Okay, well, that wraps it up for week 52. We'll look forward to seeing you all when we switch to a monthly cadence. And don't forget, we're always here as a resource 24/7. You can reach us by different mechanisms. Email is always a good way to reach out at info@workcare.com. We can't thank you enough for your loyalty and participating in our weekly webinars, and we look forward to seeing you back here on April 7th. As always, thank you, Dr. Harris, for all your expertise and your contributions to the field and health and safety across the planet.
Excellent. Thanks, everyone.
A couple weeks.
Awesome. Thanks, everyone. We appreciate you, and we'll still say stay safe and God bless.